This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Stacey Clardy from the Salt Lake City VA and the University of Utah, and today we're going to go through an in-depth update on myositis. And this is something every neurologist needs to know, right? So I want to go over what every practicing neurologist should be aware of in terms of updates related to diagnosis, treatment, and management. And so who better to walk us through that than Andrew Mammen. Andy is the senior investigator and leader of the muscle disease unit at the NIH's National Institute of Arthritis and Musculoskeletal and Skin Diseases, NIAMS for short. He's also adjunct professor of neurology and medicine at Johns Hopkins and co-founder of the Johns Hopkins Myositis Center. Andy is well known to our long-term podcast listeners. We've had the pleasure of hosting Andy many times before. Recently, probably most recently, maybe back in 2019 already, where we really dove in on MI2 dermatomyositis, a specific antibody that causes dermatomyositis. And if you go even further back, 10 years ago, there was a fantastic series of conversations throughout the entire month of May 2015 on immune-mediated necrotizing myopathies between Ted Burns and Andy. Those are all still available. You can search them up however you're listening to the podcast in our archives. But today, Andy, welcome back.
Great to be here.
No, thank you. Thank you. So I'm hoping you're going to give us some fresh insights, new strategies in antibody guide diagnosis, the evolving roles of MRI or versus biopsy, and treatment advances. I'm hoping some of these immunotherapies that have emerged since the last time we talked are having relevance in myositis. So there is so much to discuss about developments in myositis that we are going to break this into a 2-episode series. For the first half, we're going to get into what are the different types of myositis? How do we know how to make the diagnosis? What are the tools we have at hand? And what are the roles in the modern era of MRI and or biopsy? And then for the second half, we're going to talk more about the treatments. We're going to get into some complex cases and get Andy's opinion on that. And then also a little bit more about some mimics as well and where the field and research are going. Let's start broad. I am a neurologist who's more comfortable with the central nervous system, and I may be a little embarrassed to admit sometimes I have trouble explaining to patients all the different flavors of myositis. So today, 2025, what exactly falls under that umbrella diagnosis of myositis?
I think if you asked different myositis experts, you'd probably get some different answers to this question. But in my practice, I really think in terms of there being 6 major types of myositis. Now, under each one of those, there are various subtypes. But I think the first major type is dermatomyositis. And as the name implies, those patients tend to have both skin and muscle involvement, although they can have just one of those. The second major form of myositis is what we really now refer to as the anti-synthetase syndrome. And that is defined by the presence of autoantibodies recognizing a tRNA synthetase. We may talk about those a little bit more as we go. The third major type is immune-mediated necrotizing myopathy. The fourth major type is what I call overlap myositis. And that is when myositis occurs in the context of another rheumatologic condition like lupus or scleroderma. And then the new kid on the block is immune checkpoint inhibitor triggered myositis. So myositis can be a side effect of those new treatments for cancer. So it's important to know a little bit about those as well. And then, of course, there's inclusion body myositis, which is kind of a unique form of myositis. It has, unlike the other types that I just talked about, a unique presentation with not just proximal muscle weakness, but prominent, often exclusively distal weakness. And unlike those other types of myositis, it generally does not respond to immunosuppression. Those are the 6 major types. And some of you may be asking, well, what about polymyositis? What happened to that? And I think most of us now recognize that polymyositis, if it exists, is pretty rare, and that patients previously diagnosed with polymyositis are most likely to have the antisynthetase syndrome without a rash, or overlap myositis, or inclusion body myositis. And finally, some of those patients that would, years ago have been diagnosed with polymyositis actually have an inherited muscle disease. So those are the major 6 types. And when I hear that somebody has a diagnosis of polymyositis, which is not one of those 6, my conclusion is that we don't really have a definitive diagnosis yet. I still need to think hard about what the real diagnosis is in that patient.
Okay, so 6 categories, and I can officially forget about polymyositis. I love it. And you've added in there for me the immune checkpoint inhibitors, and that's a new one, but I feel like I can get a pretty good clue on that one based on history. Several of these, I don't think I'll be able to know which one I might be looking at it based on history alone. So how do I make the diagnosis now? What's the best way to start? Let's say I'm considering, 2 or 3 of them.
I think that myositis-specific autoantibodies have been around for quite a while, and the idea of using them to help make a diagnosis and classify patients into different types of myositis is not new. But I think that most of us now have better access to quality testing for myositis-specific autoantibodies, and we know more about all the different myositis-specific autoantibodies that there are, and we understand more about the clinical phenotypes that are associated with each one. So I actually really like to know what myositis-specific autoantibody a patient has, and that really helps me understand what type of myositis they have. And so, I already mentioned the antisynthetase syndrome. That might be the most obvious example because the antisynthetase syndrome is defined by the presence of an autoantibody against one of the tRNA synthetases. And histidyl tRNA synthetase, or Jo1, is the most common. So if you have myositis or arthritis or interstitial lung disease or some combination of those, and you have the antibody, then you have the antisynthetase syndrome. Another example would be immune-mediated necrotizing myopathy. So we now recognize there are really 3 different flavors of immune-mediated necrotizing myopathy that depend on which autoantibody you have. So there are autoantibodies against the signal recognition particle or HMG-CoA reductase that define different flavors, if you will, or subtypes of immune-mediated necrotizing myopathy. And then some people consider patients with negative myositis-specific autoantibodies, but a necrotizing myopathy on muscle biopsy to have seronegative immune-mediated necrotizing myopathy. So it can be helpful in terms of putting a patient into one of those 6 major types of myositis. And it also helps you put the patient in the appropriate subtype of myositis. So an example would be in dermatomyositis, there are at least 4 different subtypes that are determined by which autoantibody you have. And while all of these patients may have skin rashes and muscle involvement, there are key differences between these 4 different subtypes. So I'll just mention a few of the ones I think are most important. So first of all, if you have dermatomyositis with an autoantibody against TIF1 gamma or NXP2, well, first of all, those are dermatomyositis-specific autoantibodies, so that helps you know that it's dermatomyositis. But those 2 in particular, TIF1 gamma and NXP2, are associated with significantly increased risk of malignancy. And so those patients are really going to require careful cancer screening for the next 3 years after the time of diagnosis. Another example where the autoantibody can be very helpful in diagnosis and prognosis in dermatomyositis is if a dermatomyositis patient has antibodies recognizing a protein called MDA5. Because those patients, unlike the other dermatomyositis patients, are quite likely to have interstitial lung disease. And I think as a neurologist, it's important to recognize that and refer to the appropriate pulmonary specialist right away. And again, it used to be that reliable myositis autoantibody testing was difficult to get, but I think that's changed a lot in recent years. At least in the United States, most of the big commercial labs offer pretty reliable testing of myositis autoantibody panels where you can look at a bunch of them together. And If you're a myositis geek like I am, you can learn a lot about the different types of testing that are available for each of the different autoantibodies and get into the nitty gritty. And we could have a whole podcast that no one would listen to on that. But I do have a couple of tips. The first is that they're just sort of generally applicable. If you get a positive myositis-specific autoantibody test that is not consistent with the patient's clinical picture, that makes me suspicious. And I would consider having it retested at a different lab, preferentially one that uses perhaps a different technique to define the presence of the autoantibody. And the other thing is, just because a patient doesn't have a myositis-specific autoantibody doesn't mean they don't have myositis. Probably only about 70% of the patients have a defined myositis-specific autoantibody, and that's definitely true for dermatomyositis patients. And it's probably the case that we just haven't discovered all of them yet. So a myositis-specific autoantibody can be super helpful for diagnosis and prognosis, but if you don't find one, certainly doesn't mean you're going to be ruling out myositis as a possibility.
Got it. I've found maybe over the past few years, what I've done is combined my testing tiers together. And I want your opinion on if you have done similar or suggestions that you might have. So if a patient was sitting in front of me and we have that talk and I say, okay, is it your joints? Is it your bones? Is it your nerves? Or is it your muscle? And they're really clear to me that their muscle hurts. Think back in the day, I might have sent a CK, an aldolase, and maybe sent off some of those rheumatologic antibodies. And then when they came back for a follow-up visit, if I wasn't getting the answer and the story was still the same, then I might have gone to the myositis panels. But now I've sort of collapsed all that together, mostly because I think it was you that told me the CK and aldolase can be negative in these patients. Am I remembering that right?
Yeah, so it depends on the type of myositis. So patients with dermatomyositis or the antisynthetase syndrome can definitely have normal CK levels despite having active muscle disease. And that's because the CK only goes up if you have necrosis of muscle cells, and the CK then leaks out. But patients with dermatomyositis and antisynthetase syndrome can have muscle dysfunction due to atrophy and other processes that don't lead to CK elevations. So you can't rely on the CK being elevated at the time of diagnosis or, in the event of a flare to make sure that they really have active muscle disease. So I think that sending a myositis panel early when it's on the differential completely makes sense. The other thing I would add to what you said is that if a patient does have muscle pain and a normal CK and no muscle weakness, another thing to consider is the possibility that they have fasciitis. So we have definitely seen patients who present exactly that way. Muscle pain, which what they describe as muscle pain, no weakness on exam, CK is normal. EMG does not show a myopathic process, but when you do an MRI, you can see, significant fascial inflammation, and that needs to be treated with immunosuppressive agents like corticosteroids. And you can miss that if you don't do an MRI. So that would be a little plug for one of the contexts in which getting a muscle MRI can be helpful.
Well, that is helpful. I was going to ask you that. I imagine it would also be important to cue our radiology colleagues who are interpreting that you're looking for myositis versus fasciitis. So that's a great tip.
And then I would say, just like it's good to look at brain MRIs yourself, although I would want somebody looking over my shoulder if I were doing that, it's also good to look at the muscle MRIs yourself if you order them and sort of get used to trying to interpret them in the context of your clinical knowledge of the patient as well.
And I will say the myositis panel, as you mentioned, I've noticed this too. You really have it dialed in the muscle world more than we do in, say, like the CNS autoimmunity world where, oh my goodness, it's so confusing sometimes for folks to know which panel to order. It seems like your panels, whichever one you have at your facility, at least speaking to where I am, they just add the new antibodies on. It's still all one panel. It's kind of wonderful for me because I don't have to know the latest discovery or validated antibody. So that I have found quite helpful.
Good. Yeah, the exception to that, which I hate to even mention, but I think I have to, is anti-HMGCR testing,
We
which
have that on mine.
sometimes has to be added. Oh, maybe you've customized your panel, but some of the commercial panels require it to be ordered separately. So if that's on your differential, you just need to make sure you order that at the same time.
Yeah. I just got an email from our commercial lab, and they have added it to the panel. I was very excited.
And this may be a good time for me to say, although I'm one of the patent holders for that test, I don't get any compensation for that anymore now that I'm at the NIH. So that was a hopefully unbiased response.
Noted. And I did not know that, but yeah, thanks for sharing that. Yeah, I think increasingly people are seeing that it's important, right? And again, that's why I like there's one panel for most of us at most of our centers. The other thing I picked up on, and this is maybe just a little bit of a technical question, but can you clarify for us, because you were talking about necrotizing myopathy as a type of myositis. So the word myopathy versus myositis in this context?
Yeah, I think there's just different people prefer different nomenclature. I will use multiple terms to describe the same thing. So I might say statin-triggered, immune-mediated necrotizing myopathy with anti-HMGCR antibodies. I might just call it anti-HMGCR myopathy or anti-HMGCR myositis. I don't think that there is a completely universally accepted way of talking about those. But if I put the antibody in front of the word myopathy, I am implying that it is immune mediated.
Got it. Okay, so somewhat interchangeable, and I shouldn't focus too much that I'm missing. One implies inflammation more than the other, but both of them, it's a abnormal process. Yeah.
Yep.
Okay, and then you just started to allude to this a little bit about using MRI for diagnosis, and I kind of maybe have a combined question related to that. So I now know you use it to help with diagnosis in certain situations. I'm curious if you use it to track response as well. And the flip side of that question is, are you using biopsy anymore? I mean, when is the last time you honestly biopsied someone in your clinic?
So those are two good and, as you suggest, related questions. So in terms of MRI, I'm a big fan of muscle MRI, and I usually do thigh MRIs when I first see a myositis or myopathy patient. And MRI can tell you quite a lot. Obviously, I think what most people think of is showing intramuscular edema, and that is very suggestive of myositis. It's also important to remember that you can see intramuscular edema in other types of myopathy. So genetic muscle disease can have edema, just like an inflammatory muscle disease. And you can even see it in active neurogenic processes. So we have done thigh MRIs in patients who turn out to have ALS, and there'll be diffuse edema in the muscle, and a radiologist may even describe it as myositis in the muscle. So intramuscular edema, that's the first thing you're looking for. Another key thing is that it can tell you a lot about the pattern of muscle involvement. And you can see with the MRI disease activity even in muscle groups that aren't weak and where you can't detect it on exam. And that can be helpful diagnostically as well. And an example of that would be an early inclusion body myositis patient may not have definitive quadriceps weakness on your exam, but you can tell that the quadriceps are preferentially affected compared to the hamstrings on MRI, and that can be helpful diagnostically. The other thing that MRI is useful for is determining how much of the muscle has been turned into fat or connective tissue. In other words, how much permanent damage has been done to the muscle. And I think this is helpful when you're trying to estimate how much of a patient's current weakness is due to active and reversible disease versus how much is due to permanent muscle damage that's not going to get better even with effective treatment. And then again, I've already talked about fasciitis. So to be honest, I don't routinely use MRI to track response to therapy, but there are some situations in which I do repeat a muscle MRI. One example of that would be in a dermatomyositis patient who has muscle weakness without a CK elevation, and I'm not sure whether the weakness is due to active disease or permanent muscle damage, and a muscle MRI can be helpful in that situation. So I do a lot of muscle MRI and find it to be useful. Muscle biopsy, I got interested in myositis and muscle disease when I was a neuromuscular fellow looking at muscle tissue under the microscope. So I love looking at muscle biopsies. And when I was in training, people would say, you need to do a muscle biopsy in all myositis patients because you need to exclude other diagnoses. That'd be one major reason. And I'm not sure I buy that so much. I definitely do many fewer diagnostic open muscle biopsies than I used to do. In patients with suspected genetic muscle disease, I'm going to order gene testing and only do a muscle biopsy if that's unrevealing. In a patient who has a myositis-specific autoantibody, there's usually nothing to be gained from doing a muscle biopsy because the serology is already telling me pretty much all I'm going to know and need to know about that person's disease. Another situation where I'm not going to do a muscle biopsy is if a patient has a definite dermatomyositis rash. Even if they don't have a myositis-specific autoantibody, if you've got heliotrope and Gottron sign, that is really just pathognomonic for dermatomyositis. And getting a muscle biopsy is, it may also show you the patient has dermatomyositis, but it's not really going to change your treatment. So as a rule, these days, I only do diagnostic muscle biopsies to answer specific clinical questions. So one example of this in my practice would be, I get referred a fair number of patients with lupus who are taking hydroxychloroquine and then develop proximal muscle weakness with a CK elevation. And the differential there is myositis versus a toxic myopathy from the hydroxychloroquine. And sometimes rheumatologists really don't want to stop the hydroxychloroquine just to figure this out. And so I may do a muscle biopsy in that case to demonstrate to myself and the rheumatologist and the patient that, this is myositis, not hydroxychloroquine myopathy or the reverse. Another example of where I do a muscle biopsy, I had a recent patient with an unusual pattern of weakness who had multiple EMGs before I saw him with conflicting interpretations. Some showed a predominantly neurogenic process, other ones showed a predominantly myopathic process, and I got a muscle biopsy to try to sort that out. In that case, it turned out to be both. I'm also, ambivalent about getting muscle biopsies in patients with a typical story and a typical exam for inclusion body myositis. I'm usually pretty confident about that diagnosis, but all the diagnostic and classification criteria that I know of for inclusion body myositis really require a muscle biopsy. So I usually am offering that to patients. And I will note that many of these patients are interested in clinical trials. And for IBM clinical trials, as far as I know, they all require muscle biopsy diagnosed disease in order to enter the trial. So IBM is another situation where I will often get a muscle biopsy.
This helps me a lot to know when to call for help sooner versus later. If inclusion body myositis is on there, I'm going to refer immediately to expertise to get that biopsy. Please join us for the next episode where we will get more into treatments and the future of myositis and the ongoing research. We'll see you then. This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.